We'll very briefly examine that the methods that were used to come up with some of the recommendations and guidelines that I'll be sharing with you. We'll talk about language and health, healthcare experiences, and public opinion, as well as look at some practical recommendations to enhance communication with and about people living with diabetes. So hopefully these will be things that will be useful to you in your practice and your work with people living with diabetes. So the objectives for today are, first and foremost, to develop a greater awareness of the impact of language that's used when speaking with and about people living with diabetes. Next, it's my hope that you will learn some practical tools and communication techniques that promote inclusive, equitable, and value-based language. And then finally, you should be able to contribute to the improved mental, emotional, and physical well-being of maybe not you personally helping the 11 million Canadians living with diabetes and pre-diabetes, but certainly the people that you work with in your practice. So I'd like to start by showing a video by one of today's kind of emotional gurus, Brene Brown. And as you watch this, I'd like you to think through, why would I be showing you this video that has to do with sympathy and empathy? And how does it relate to language, and how does it relate to the practice that you're currently working in?
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay. That's just a fun. That always surprises me, that ending, not the first time. So again, looking at that and reflecting, why would I show you this video? Well, because while we're looking today at practical forms of communication, what we're really trying to do via language is understand the people with diabetes that we work with. So in order to do that, we have to get into their minds and into their lives, because that is how we co-construct solutions that will be helpful for them. It also means demonstrating your own sense of understanding and being able to portray that you get that this is a struggle, that it isn't easy, and that you're there to help without judgment. So why does language matter? Well, because we understand the world through it is really what it comes down to. Our thought comes to us primarily in language. So the language that is available to us helps us not only express ourselves, but helps to define situations and give us frameworks for how to feel about what we are experiencing. The way that language is used, both verbally and written, reflects and shapes our thoughts, beliefs, and behaviors. And it has the power to persuade, change, or reinforce beliefs, discourse, and stereotypes. And that's for better or for worse. Language does more than reflect people's reality. It really helps to create it. So because of that, language plays a role in defining people in terms of their identity and their health. Language and the attitude that it reflects can affect self-confidence and motivation. It can influence health and well-being directly or indirectly. You know, people who are ashamed find it much harder to engage and manage their condition proactively. And there are certain words and phrases that can be demotivating, inaccurate, or even harmful. So when communicating with and about people with diabetes, it's important to consider how your choice of language could affect their thoughts, feelings, and behaviors. So a quick word on methods. What I'm presenting today is based on a larger piece of work, a consensus statement that was published in the Canadian Journal of Diabetes about the language to be used when speaking with and about people living with diabetes. So we, the authors of the paper, which included members of the professional section of Diabetes Canada staff, which I was at the time that this was written, and patient partners living with diabetes, we collectively consulted relevant stakeholders, including healthcare professionals. And some of you might have even filled out a survey for us or participated in a workshop at the time. And we also included people living with diabetes in order to develop these recommendations and make sure that what we were putting out accurately reflects their experiences. So for the purposes of time, I won't delve too deeply into the methods involved, but please do feel free to consult the paper. It's hyperlinked on the slides, which you'll have access to after, and reach out should you have any further questions. So there's a great deal of confusion among the public and even some people living with diabetes as to what this condition is. And that's partly because of how broadly it's discussed. So as most of us here are aware, diabetes is not a single condition. It's an umbrella term for a collection of conditions with similar symptoms, but very different causes, progressions, and prognoses. At times, it is possible to speak about diabetes, and this is primarily when we're speaking about factors that are common to all types, such as the need to monitor blood glucose levels. However, most often, it's important to be type specific. So talking in generalities perpetuates and overextends inaccurate ideas. One common example of this is Diabetes Canada has advocated for a levy on sugar-sweetened beverages because of their direct link to the development of type 2 diabetes. But in the public, this is often discussed as, you know, a levy helping to prevent the development of diabetes in general. And this leads to an overgeneralized understanding that no person living with diabetes or prediabetes should be consuming sugar-sweetened beverages. But as we know, for people with type 1 diabetes, sugar-sweetened beverages are easy go-tos when they're experiencing a low. They're accessible, they can generally be found not too far from home or wherever somebody happens to be. So for these reasons and others, it's important for us, when possible, to start to be type specific when addressing factors that are unique to a particular type of diabetes. Next is language and how it relates to power. So I've inserted an image here of what I would characterize as kind of the old school physician with a particular type of relationship to the people for whom he cared. Traditionally, doctors worked under more of a one-way flow of information, where there was this kind of doctor knows best model and patients are seen as passive recipients of their advice. Doctors or healthcare providers, held status and authority and were left largely unquestioned. And there was very much a follow doctor's orders approach to providing healthcare. So in these doctor-patient relationships, there was a real power imbalance. And that is something that we're trying to move away from today. And I think that we've made some great strides already. We are hoping that this work will contribute to a larger cultural shift in healthcare, where patient engagement and patient-centered care has already really started to become the approach to emulate and aspire to for many, and for good reason. Patients report better experiences, and centering care plans around an individual's life circumstances often results in much better health outcomes. So one of the things that can be problematic in terms of this power dynamic is the overuse of medical jargon, which can reinforce this more traditional patient-physician relationship and result in patients feeling less than, or it can promote a sense of distrust in their healthcare provider. Because if somebody uses a different language than you, something that you don't understand, we find it harder to connect and relate to them. They seem different to us. So if doctors are using a ton of medical jargon that doesn't make sense, what ends up happening, to use something that's very popular in popular discourse today, is people feel as though their doctor or physician is not part of their tribe, right? It's harder to relate. It's harder to feel that sense of connection. So trying not to use jargon is important. And instead, it's much more helpful to listen to the words that the person with diabetes uses and try to reflect that language back to them. This really involves working towards using language that is collaborative and engaging rather than authoritative and controlling. And this is where values comes in. In the domains of policy, science, medicine, many of us have been trained to be objective, right? And to focus on evidence and hard facts. When we do that, however, it becomes much more difficult to connect, and our messages are less likely to be absorbed by the people with whom we're working. Instead, operating in the realm of shared values underscores common ground. You can develop common goals, and it gives a sense of consensus, or helps to develop and build a sense of consensus. These discussions, value-based discussions, are far more likely to draw people in and help build trust, because they don't work at the level of the mind. They work at the level of the heart, and they produce a sense of meaning. As much as we would like to believe that we are all rational beings going around in the world making choices based purely on information, a lot of research demonstrates that we are far more likely to follow our gut and to follow what feels right to us. And this is very much about meaning and what certain outcomes or behaviors mean to people's lives. And then conversely, it has to do quite a bit with what their current life commitments and priorities mean for the course of their self-management. So working to connect to the people with whom you work at a level of values will be helpful in co-constructing care plans that people feel motivated to and capable of carrying out. Another reason that language is important, or another way that it can impact people's health outcomes and their trajectories, is labeling. And one of the things that's most important and has really started to take hold already is using first-person language. So people living with diabetes have really taken issue with the terms diabetic and patient. And that's primarily because each of these defines the individual as their health condition and positions diabetes as the defining factor in their life. For many, these terms overextend the salience of living with diabetes and define them as their condition, when diabetes is but one aspect of their lived experience. And being a patient, for example, takes up a fraction of their time. They are people, they have other roles. And people are individuals with their own preferences, priorities, and lives beyond diabetes. Other issues that people living with diabetes have told us they're not huge fans of are sick, ill, or suffering. They feel that these are very negative, and they question, is everyone living with diabetes suffering from diabetes? Does this have to be true? Not everyone feels that way, and some find that this language positions them as helpless victims and powerless to lead a normal life when they feel there's really no intrinsic reason for that to be true. Now, a little word of caution here. It's important to remember that everyone is different. So while today we will discuss some recommended language, not everyone will respond the same way to its use. Some people might object or be irritated by certain language, so really listening to the people that you work with is important. So an example here would be, the term diabetic. People living with type 1 diabetes are sometimes more comfortable with the term diabetic because diabetes plays such a prominent role in their daily lives that they do identify with their condition to a very intense degree. It permeates their life course and their daily decisions. So the recommendations that I'm making here are not hard and fast rules. What I think is important to take away is a sense of awareness and sensitivity to how people are responding to the language that we use. Now, sometimes the language that we use can be inappropriate. In clinical practice, the terms bad or poorly controlled, badly or poorly controlled, non-adherent or failing are quite common. And although these terms are attempting to point towards certain factors of one's health that could be more optimally managed, there are issues with these terms. And I'd like, if you will indulge me, to involve a bit of audience participation here. I'm wondering if you could respond in the Q&A, and Grace will help facilitate. What are the issues that you think come along with these terms? So put yourself in the shoes of someone who's living with diabetes, and how do you think it would feel to be described as non-adherent or having poor control? What are the issues with these terms?
So you have implies the person isn't trying, that they're less of a person, lazy, stupid. These are some of the answers that are coming in.
Yeah, that's great, Grace. And thanks to those of you who shared some answers. Yeah, I mean, you're getting at the crux of the issues associated with these terms, that they're based on the assumption. First of all, one issue is that they're based on the assumption that diabetes is predictable and that following orders will result in perfect blood glucose levels all the time, which we know is not true. Blood glucose and A1Cs change in response to many controllable as well as uncontrollable factors. Also, there's the issue that diabetes is a progressive condition. So despite people's best efforts, they may require more intensive treatments such as insulin, which many people end up psychologically resistant to. Talk about insulin resistance, then there's psychological insulin resistance, because it's been used as a threat to them for so long. If you don't improve your control, you'll end up on insulin. It's used as a threat. So it then becomes something to be feared, or that makes them feel like a failure instead of a support in aid of self-management. As a few of you also mentioned, this term also implies that people living with diabetes are either being difficult, irresponsible, uncooperative, and these types of attempts at persuasion disregard people's beliefs, priorities, values, skills, and constraints. Focusing on those pieces instead is often key to improving management plans and outcomes. So, for example, people who are non-compliant might actually be making very valid choices that are consistent with their explanatory models, experience, and lifestyle. So some of the work that I did was looking at people living with diabetes in urban centers, and particularly in Toronto and Vancouver. And what I found is that people who are using insulin as a form of self-management often will let their blood sugars run high before they go on public transit, and particularly before they use the subway, because their fear of becoming hypoglycemic should the subway break down, should they be stuck for a long period of time, that fear is scarier to them than the potential for long-term consequences by having blood sugar levels that are slightly elevated. So without such information, it's very hard to find practical solutions that work for the people that we work with. Using these terms and labels can really lead us down a path where we miss an opportunity to ask relevant questions and develop collaborative goals and tailor treatment plans. And it also might get us thinking in a way that blocks our capacity to acknowledge and encourage the activities that someone is doing well. And just because, we take away the non or poorly or bad doesn't mean that the terms compliant, adherent, and well-controlled should be welcome for use either. Because these primarily imply that acceptance of someone's actions and decisions are contingent on the extent to which they align with healthcare professionals' priorities, and that such approval may be withdrawn. They do not imply understanding and care. So another big issue that we see that is a function of language also is stigma, stereotyping, shame, and blame. For people living with diabetes, feelings of failure, frustration, and self-blame are common consequences of unrealistic expectations, and these are reinforced by inaccurate and unfair stories and images that we see perpetuated in the media. So, for example, news stories that discuss people living with type 2 diabetes often portray images of people walking around who are living with overweight, wandering around with ice cream in hand, or something similar to the image that I've put on the slide here. These are really not neutral images. They are heavily associated with morality and judgment. And so stigmatized is type 2 diabetes, for example, that individuals living with type 1 diabetes that we consulted for this work actually suggested that we rename the conditions altogether, because when they would tell people they had diabetes, they would automatically be met with judgment of having brought it on themselves, having a lack of willpower, overindulging, and they would have to make the case, no, I don't have that kind of diabetes. So people with type 1 are working to distance themselves from the stigma of type 2, which overshadows their experience. And they thought it would be easier to just rename everything than to actually work on the issue at hand, which is the perpetuation of these very harmful and stigmatizing ideas. So the use of this imagery and language that over-identifies type 2 diabetes as a condition brought on due to lifestyle factors is inaccurate and harmful. I mean, how so? We can all probably count millions of ways. We know that type 2 diabetes is a result of environmental, genetic, and behavioral factors, and that even people who do all the right things are at risk of developing the condition. These stories and images also insinuate that people are lazy and making poor, indulgent choices and don't acknowledge the very real economic and cultural impacts on how we choose to eat. I even take issue with the term lifestyle because it implies this use of choice. And the capacity to live a healthy lifestyle is not equally distributed among the population. So not all choices are available to all people. In clinical practice, these narratives and the very real weight bias that many people encounter in the healthcare system may lead people to stop confiding in their healthcare professionals or family members or friends, or even doing things such as asking for accommodations at work because they're afraid of judgment or negative responses. And this has an impact on health outcomes. So while I focus this section on stigma on type 2 diabetes, stigma is prevalent in type 1 as well, both for adults and children, and even for people living with prediabetes. It manifests itself differently, but it's still part of their daily experiences. So if this is the case, what kind of language then is needed? Well, above all here, we're looking for language that is inclusive, collaborative, and values-based. We're looking for language that encourages and enables people with diabetes to actively participate in their self-care. We're looking for language that reflects a holistic approach that deals with people at the level of their entire lives, not just with their diabetes control. You know, diabetes is frustrating and challenging and distressing, and focusing on the choices that they're making in their everyday lives that can be encouraged and working with them to figure out what the barriers are to optimal self-management is far more effective. We may not be able to help everyone address these barriers, but at least dismissing them and their very real efforts that they are making is unhelpful. We're also looking for language that informs but does not judge. So we want to avoid blame and any language that implies moral judgment about behaviors. We always have to keep in mind that individuals have the right to make choices, that they have responsibility for their condition, that there are some very real societal and structural factors that act as barriers to optimal self-management, and that diabetes at any point may not be the priority in this person's life. At its base, we're looking for language that expresses empathy and promotes connection. So to provide some practical recommendations, I've taken a list from our paper and inserted them here in this slide. And we'll go through just a few, not all of them. There's a general move away from describing diabetes as a disease. You know, disease has very negative connotations, and it's seen as something that may be contagious or something that is to be feared. Diabetes is much better understood as a chronic condition that people will live with for the rest of their lives and work towards managing. Blood tests. Well, tests imply success or failure, and they also imply an end result, that you finish, you move on to another activity. Rather, people living with diabetes need to monitor their changing blood glucose levels throughout their lives. So it's much more appropriate and helpful to use the terms checking, monitoring, self-monitoring. A big issue that we have are with the terms should, should not, could, wouldn't, can't, must, have to. Discussing diabetes management options or self-management choices is much more helpful in that it encourages people to be actively involved in the decision-making processes about their own health, and it makes it more likely that they will be able to keep up with the decisions that you co-construct or that you co-make. So instead, it's more helpful to suggest treatment options which emphasize which choices are available and also acknowledges that person's autonomy and capacity to make decisions based on what's best for their life. These kind of should and should not terms come up a lot when we talk about eating and nutritional advice. And they can be very harmful because people living with diabetes often feel judged by others, including health professionals, but they also feel policed by their friends and families about their food choices and eating habits. We know that food is fuel, and it is most certainly a means to managing diabetes. However, many other factors influence how people eat, including psychological functions such as emotion regulation and reward. Healthy eating is important, but putting this advice into practice can be a struggle. So for those using food for emotional reasons, extra support may be needed. And then of course, there are other factors such as cost and food security that add even more complications to this narrative of choice and what you just should and should not be doing. So again, coming back to these terms such as you could consider, you could try, here are some options. These are far more helpful and less directive. We want to focus the conversations not on what or how much somebody is eating, but try instead to explore reasons why someone eats why they do. This is a much more helpful discussion, and it opens, opening conversations with things such as, there are many reasons why we eat what we eat. Would you like to talk about them? That might help you get more information that would be useful for directing people differently or helping them develop better strategies. We already discussed the issues with controlled, poorly controlled. So instead of using those terms, we want to acknowledge that blood glucose levels can be influenced by the person with diabetes, but not expect they can ever be truly controlled. So asking questions such as, what is your diabetes control like, really does not take their entire life into consideration. It's too focused on their diabetes. Instead, asking things such as, how is diabetes affecting life in general, is going to be more useful. So we can ask, can we talk for a few minutes about your blood glucose levels so that I have a better idea of how things are going for you? That opens up a much more open discussion. And then the terms failed, failing to, we talked about those earlier as well. It's probably more helpful to rely on terms such as, this person did not, they have not, on this occasion didn't, was unable to. Failure implies that someone has tried and missed the target, and it implies a lack of achievement, ineffective efforts, or a lack of effort. It also implies disappointment on the part of the person using the term, and it is much better to rely on certain facts and avoid judgment about those facts. I think one of the conversations that really drove this idea about the problematic use of the term failure home for me was when I did a presentation somewhat similar to this with a support group for women experiencing gestational diabetes. And they talked about how difficult it was for them to hear the term failure, because they felt like not only were they failing themselves, they were failing their babies. And the weight of that guilt when they would wake up in the morning with high blood sugar levels, for example, it was completely demoralizing, and it made the situation more scary than it really had to be. So in conclusion, I'll just provide some practical tips to enhancing communication. What I provided here in this presentation and in the document that we produced are some recommendations, but these vary based on individuals. So using these guidelines provided as opposed to following a very particular set of language rules will be most helpful in discerning when and how to best mobilize language to support the people with whom you work. We want to be aware that language, both verbal and nonverbal, has enormous power, and which can have positive or negative effects. So we want to be alert to our body language and recognize when it may be closing us off to further discussions or putting the person that we're working with off. There are some words, phrases, and descriptions that are potentially problematic, whatever the intention of the user. So there's what we say and what our intention is, and then what our audience hears. And these do not always align. And that's why that checking in and checking on that value-based language is always something that we encourage. We want to be aware that the language being used not only in interactions with people living with diabetes, but when speaking with other healthcare providers and in writing matters as well. What we're looking to promote here again is that cultural shift that moves us towards more collaborative engagement models. So reinforcing that in all of our own activities is a good way to move forward. And then above all, it's important that we remember that language not only reflects, but creates reality. So people with diabetes need to know that their continual efforts to improve their health and self-care activities are worthwhile and valued. Focusing on the positive changes that they make and can continue to make in the future is more effective than focusing on past behaviors and outcomes. And I think that I will end things there. Thank you all very much for attending, and I will open the floor for any discussions, questions. Thank you.
Yeah, so if you have
Grace.
Yeah, so if you have any questions, please type them in the Q&A box, and we will see if Krista will answer them for us. Just gonna wait to see if any pop in. So maybe while we're waiting for if people have questions, do you want to just advance the slides?
Yeah.
Just one more. While folks are here, I just wanted to let you know about Diabetes Canada's upcoming webinar. So on October 22nd, Daniel Burton will be speaking on vaccinations, diabetes, and now COVID-19, specifically some focusing on influenza. I know this is certainly an interesting discussion with everything that's happening with COVID, but how, we're coming up on flu season. So yeah, that's on October 22nd at 12 p.m. Eastern. On November 12th at 12 p.m. Eastern, we'll have the latest advances in pediatric care for the diabetes educator, presented by Susan Kettle and Sandy Hubbard. So you can register at the same place you registered for today's webinar on Timed Right. So if you want to go back, there are some questions that have popped in. So someone was asking if you have any tips on managing language within a group. So how not to police, but to move forward together.
That's a great question. So particularly, yes, when you're working with people that are coming together as part of a support group or a self-management group, perhaps you're providing dietary advice to an entire class or coaching. I think my number one advice would be not to put anyone down for whatever language they use, but take that as an opportunity to reframe it, right? When somebody says something, you can reflect that idea back to them using language that is much more collaborative, values-based, and inclusive. And hopefully that will help pull other people into that way of speaking and thinking.
Great. So actually someone was asking, said, given the stigma and dislike of the use of the word patient, they noticed at the beginning of the presentation, you referred to yourself as patient partners. Just any comments on that?
This is an excellent question. And I always anticipate that there will be at least a few very astute people in the audience who recognize. So what happens with language is that it evolves at different rates in different places. So while sometimes the language that we use between people within interactions evolves more quickly, sometimes it requires institutional practices to change as well. What we have with the term patient is a situation where funding bodies, research bodies, a lot of people are still actively asking us to describe patient. How did we engage patients? How have patients been involved? So for example, even here, the Diabetes Action Canada participants, our patient partners, kind of begrudgingly accept the term because they recognize, even though they don't feel that patient is appropriate, it still has some cachet. So we're kind of at that in-between point where we're moving on from being patient-centered to being person-centered care, but there are some institutional bodies that haven't yet caught on. So we're still, that evolution is not yet complete.
Great, thank you. This is, I think, more of a comment, but just someone is a dietitian and they usually use the term that they're not the food police, but they're there to coach and support you. And then one last question is, how do we respond to those who choose to use traditional medicine? Yeah, that's the question. How do we respond to those who choose to use traditional medicine? So I'm wondering if that might be yeah, maybe if you, the person who asked that question, maybe just wanted to clarify. I'm wondering if it meant non-traditional medicine, but we'll just wait to see if nothing yet. Those are.
So I can respond based on how I took that question, but again, my interpretation of your language might be different than the way it was originally intended. So I apologize if I'm going off on a bit of a tangent. The way that I hear that question is, how do we respond to people who are still using kind of the old terms? I know that that's come up in many of the workshops that I've used before, is that often people who will attend a webinar such as this are already people who are on board with the idea of making these switches, but there are many people who aren't. So I think this then comes down to kind of a slowly evolving, changing philosophy and changing culture of practice. And it's not going to be an interaction with any one person, but people who are using these kind of outmoded, slightly outdated forms of interaction will eventually not necessarily be left behind, but they'll see that the language that they're using, people are now, it's not in currency anymore. So this is, yeah, again, that discrepancy between here's the hard and fast rules on language versus the changing culture of healthcare, and the way we provide care.
Yeah, so we did get clarification. They just said like herbal medicine. So I'm wondering if maybe this is not so much about, you know, whether someone's following the specific, like, so say you have a patient who's not following those specific guidelines. Is there sort of language you could use that respects sort of the decisions or choices that they, you know, that they want to make or feel it's the best decision for them, while also trying to follow the practice or the guidelines that sort of Diabetes Canada has set out, or things like that? Yeah.
Okay, that's a great question. I think that it's always important to acknowledge that there is value in exploring all options. I would take the opportunity to question or to learn more about why they think this is helpful, what they think is helpful about this alternative practice, and then take some time to look at with them whether or not they're actually seeing any substantive benefits. So they might be engaged with something that makes them feel better, you know, this kind of, maybe there's no evidence behind it, but there's maybe a bit of a placebo effect or something that, you know, makes them feel good or in a bit of control. That's not harmful at all. What ends up becoming an issue is people, if they are relying on things that have been found to be harmful or are detrimental to their current circumstance. And in that situation, opening up a conversation about, well, how is this actually working? What are we seeing in terms of blood glucose monitoring, et cetera? And is there a way to try to balance that value of an alternative medicine with something that we know that we have faith that can kind of help resolve current issues that are being had?
Yeah, I think that's a really interesting discussion. I just as a note, we'll open up a discussion group on Time Right. Chris has agreed to share her slides as a PDF, so we'll upload them there. And then that's a really good, if there's conversations that want to sort of continue from today's presentation, that's a great place to be chatting, or you know, sort of, if you have a question that you think of, maybe an hour, or, you know, hopefully you're still thinking about this presentation as you leave today. So we just have this is a comment just about the presentation as a whole. So great presentation. We've been advocating for this for many years. In our Indigenous communities, the stereotypes, blame, and shame have been very heavy and very discouraging. So encouraging these is a big step in helping to make change. I think that's a good place to leave off. So someone just saying, I'm not sure why I'm being, okay, I'll just clarify. So earlier in the presentation, when we were asking people to provide feedback from on some of the things, and people put in, you know, their suggestions about, implies that the person, sort of the language, why we don't use certain language. This is, so in the Zoom platform, what happens is when I need to move those questions, like they're not a question, they're a statement, I need to move them out of the way, and the language that Zoom uses is dismiss. So it looks like I dismissed your comments. So someone asked why they're being dismissed when they wrote that I'm feeling like I'm less of a person. I mean, that's a really good example of how why language is so important. I promise we're not dismissing it. It was just a way to move it out of the question queue. So I just want to
give this presentation to the people at Zoom.
We'll let them know. I didn't want to dismiss your very valuable feedback. It's just the language that Zoom uses. So I want to thank Krista for today's presentation. I think it was really informative. I think the comment that we just got about why this is so important was very enlightening, and I think it was a great presentation. So we have some upcoming webinars. I just want to touch on a few things. Krista, if you could just advance, we'll go one further. More. So all of our webinars for our healthcare professionals are free. We provide them free for all healthcare providers. But if you found them valuable, you might also might want to consider becoming a professional member with Diabetes Canada. So it's $105 a year. You get discounts to conferences. You get, we typically do in-person events, although with everything happening with COVID, we've transitioned to doing a lot of virtual events. You would get the Canadian Journal of Diabetes. both mailed to you as well as virtual copies. The Diabetes Communicator, which has lots of great articles, things like why language is important, would be something that would be in the Diabetes Communicator. Those are all available virtually, and you'd get access to all the past editions. So consider becoming a professional member and supporting Diabetes Canada. And then we'll just advance one more slide. And Diabetes Canada could certainly use your support now more than ever. We've certainly been impacted by COVID-19 and our ability to fundraise. Our donation boxes were severely impacted during all of this, and our ability to do in-person fundraising. So again, if you found today's presentation useful, we would love your support in the form of donation if you're able to. So thanks again, Krista, for today's presentation. We hope everyone will join us. This was recorded, so if any of your colleagues you think it would be useful for them to watch, they can watch the recorded version on Time Right or on our website, diabetes.ca. Thanks for joining us. Have a great day.
Thank you. Be well, everyone.